when results and rationale don't follow patients through the continuum of care, why this matters, and what can we do about it. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Today, I have a guest named Eva Johnson, who is a speech pathologist who works in skilled nursing facilities. Also a listener to some degree to the podcast, but I reached out and was trying to get information from listeners and from other people who are following us to get an idea of what they think are some of the critical problems right now that we might be able to do something about. And so the original idea was to take three people and create an episode out of these 10-minute segments. But I thought Eva had so much to say and was so good at saying it that we should just do a whole episode. So here she is. Wait till you hear this radio voice. I'm just saying.
Hi, Tim. Good to be here.
Now that's you're exaggerating that time.
I could play it up. I could tone it down.
That's all right. Do what's natural. Do what's natural. Tell us a little more about yourself. What else do you think people should know?
Yeah. So as you mentioned, I am an SLP. I'm fairly new to the profession. I've been practicing for a few years, and I've almost exclusively worked in skilled nursing. And if I was going to represent myself in an interview as an employee, I would say what makes me unique is I get really frustrated with inefficiencies. I don't like having to repeat procedures over and over again that don't feel like they're getting any better. It makes me want to tear my hair out. And I think that has really come up a lot, particularly in swallowing, is realizing there are a lot of inefficiencies in how we work with our dysphagia patients, which is a little bit of what we're here to talk about today. Some of those inefficiencies and how we can address them in clinical practice.
All right. When I think of inefficiencies, I'm just going to say I'm slightly triggered because that makes it sound like you're a rehab director and you're like, you need to be more productive. But I think from our conversation before, actually, I know that these are inefficiencies that make our life harder. And so by fixing them, by doing these things we hopefully will talk about, it makes them easier. So tell us a little more about that.
Yeah. So the primary kind of communication inefficiency that I find myself, butting heads with at work is the incoming documentation. I have a really hard time getting a hold of any information about my patients regarding their swallows when they get to our site. That means no fees are available, no MBS is available. They may come in on a modified diet and there's no indication as to why. And people can always see me getting redder and redder at the desk going, why is this person on ground textures and nectar thick and we have no context for it? And it always makes me feel a little unsafe going into a room trying to start at zero and knowing that somebody previous to me has potentially seen some really high aspiration risk indicators.
What I'm thinking about is like if you go into a room and you don't know much about somebody, like that's one thing. But if somebody has a pre-existing diet recommendation of the magnitude of like minced diet and nectar thick liquids, it biases you, or it would bias me. Well, yes, it would. It would bias, I think, anyone to think, okay, I'm going to be looking for problems that would trigger this and perhaps make us a little bit less objective unless we have more information on the rhyme and reason, the rationale why the therapist before us made that recommendation.
Yeah, absolutely. And I mean, what we're looking at is a loss of safety data that, to your point, is potentially biasing a new clinician, new to the patient clinician. We're also looking at additional costs for this patient. They had some sort of evaluation potentially done at the hospital. And now I'm having to start all over again. We're not having a continuity of information. We're just trying to start from zero all over again. And when I'm trying to decide what are we going to target with this patient, it is affecting my plan of care. I may start them farther back in their care process than they need to be because I'm worried that even though if they did well at my bedside swallow, knowing that there was something more acute, more critical that came before, I'm trying to build that in. I'm trying to hedge. And so they're ultimately potentially spending more time doing therapeutic things that are not necessary for them.
Yeah, no, that makes sense. And that creates a lot of wasted time for you. Frustrating not to have the information, potentially biasing, and duplicates the work and ultimately inflating healthcare costs. And I think
Yeah.
a lot of that. And I think that we can bring that back around too. Like that probably has some sort of a salary implication on us too. And I mean, there are just so many ways that this could affect us that I don't think we even think about. I'm thinking of a clinical fellow or someone who's very vulnerable in their learning, and they get this patient who's maybe come from a well-respected clinician at a teaching hospital or something like that. And this patient's on a modified diet or they're pureed, nectar, whatever. And so the clinician going into the room might hear things, and they maybe, like, if they were unbiased, maybe they wouldn't think much. Maybe they'd be like, okay, this is a pretty typical evaluation, and based upon their chart and other things, there's not a lot of evidence of dysphagia or evidence of issues that I should be concerned, and make a recommendation for a modified diet. But because they know what the patient has come with, and they know that this is from a well-respected person, a well-respected place, it could potentially cause them to interpret things within the exam as being falsely alarming, right? Oh, their eyes are watering. So now, maybe that's interpreted as a sign of aspiration or something else. Like they're looking for something because they trust this person and they're trying to make their judgment congruent with this other individual's. Just a thought. Not saying that's going to happen with everybody, but there's potential for it.
I would say that having been in those shoes, I would definitely say that that is a creeping thought that you're looking for something that looks consistent with what has been documented before, not because, their swallow couldn't have improved in that time, but the only piece of evidence you've been given is meager and it's indicative of something serious. And so you're looking for something serious because you don't want to be the person who missed it. You don't want to be the person who overconfidently said, don't worry about it. I saw them at bedside with a cracker, and are suddenly, advocating for a regular texture diet that is completely inappropriate. So you end up getting caught in a tough spot.
Yeah, definitely. Oh man, there was something else in that. It went in one ear and out the other. It was important. So I'm
welcome to a lot of my day.
I'm going to give it a second here, but no, never mind. Maybe I'll come back to it if we get there. So talking about a gap in continuity of care, patients being transitioned from one facility to the next, whether it's acute to skilled nursing, acute to inpatient rehab to home health or to outpatient care, a number of different things. And so they're arriving having had a FEES or an MBS or some other sort of testing that's important, but you don't have the documentation for it, or you don't have the imaging for it to be able to help guide your care. Is that?
Yeah. Well, or we hope that it's there. Sometimes I just get a modified diet or indication of intubation or other things that would kind of make me a little more suspect with my patient, and no FEES or MBS has been performed. So sometimes it's you can't get access and sometimes it's non-existent. And so having to develop, practices to deal with this has been really critical in how I have practiced as a clinician.
Not too long ago, Ed Bice and Matt Ward, I think, and I forget who else's name was on that paper. I think there was at least another name or two, looked at diet recommendations that were made. I believe they were looking at patients, I think, in skilled nursing who had come from inpatient facilities and maybe looking at whether or not they had a diet modification recommended, and then whether or not they had instrumentation done with that. And seeing that there was a pretty big gap in patients who had diet modifications recommended without instrumentation. Now, I'm afraid I butchered that. So while you're talking at some point, I'm going to go back and look at it so I can correct myself.
Yeah. But, I think in trying to bridge the gap, which I love that that is so related to the title of what you do, we have what can we do? So we can try to standardize that handoff process, which sometimes can be, hey, can we discuss with the hospital if you work with a regular hospital, saying this is what I'm going to need, and seeing if you can get that. Or one thing I've also found really helpful is finding the right person. We have insurance and hospital liaisons. And so even though I almost never get the information on arrival, sometimes if I just hassle that person enough, I can get some additional documentation. And I highly recommend just trying to butter them up.
Mm.
Bring, I am
Not
not
hassle,
above
not
bringing
pester,
cookies.
but be a sycophants, you know.
Yeah, I'm like, oh, thank you so much for your time. I appreciate it. Do you need candy? I'm looking for this MBS, just work it into the conversation. And then obviously, like trying to advocate for more access to instrumentation. In other places I've practiced,
Mhm,
we could get access in a fairly short time frame. Like when I
mhm.
was working in DC, we could get Carolina Speech, who is renamed. I don't know what their new name
Yep,
is, but they were able to
KCSC.
come to our building under fairly quick notice. I have the difficulty of having a very high turnaround. So oftentimes I can't get a fee scheduled or an MBS scheduled before they leave the facility,
Oh yeah,
which is frustrating, but
yeah,
doesn't hurt to try.
yeah. And I mean there is not a small impact of diet modifications, and some might, I hope not, but could potentially misinterpret what I say is that they're never okay. And like I don't believe that. I think there is a time and a place for them. I'm typically pretty reserved against thickened liquids. I don't see much of a place for them, although I acknowledge there can be, right? It's just I think it's should be more of a last resort. But anyway,
Yeah.
where and we're like a very temporary resort, right? And so, or maybe improves the patient's quality of life because they cough a lot with thin liquids and it's embarrassing and they don't want to, and so this keeps them from coughing. But anyway, that's a whole different conversation. But so there is a lot out there to show that there are difference in nutritional value, difference in hydrational value with modified diets. Like if you puree food, you add liquid to it, right? And so it's less calorie dense. Not only that, but patients don't want to eat as much of it because it looks like baby
Ain't
food.
that
And
the
it's like,
truth?
I'm not a baby. Don't treat me like one. I don't want to eat this stinking food. But with the thickened liquids too, patients don't like to drink them. There was, dear, I got to get my citations better, but there was a study not too long ago. I think it looked about 25 people in acute care, and none of them who are on thickened liquids met their anticipated need, well, their calculated needs without enteral or para-enteral liquids. And I
Mhm.
think maybe one thing with that, I believe that even the most significant source of liquids for them was their food, because food contains liquid too, right?
Yeah.
And anyway, while I'm over here trying to talk nerdy, let me go back to that real fast to that Bice, and actually Bice, Gaelic, and Matthew Ward. It's published in 2024, Dysphagia and Diets in Skilled Nursing Facilities, when patients' health status changes the role of imaging. I'm just going to summarize basically part of the abstract. And so they reviewed records from 25 skilled nursing facilities with patients who were receiving swallowing therapy, their pre-diet level and their diet level pre and post fees, and if they received prior imaging. All right, so there's more about how they did the thing that they did, the results. No agreement between pre and post imaging diet levels. And then a bunch of other fancy words indicated pre imaging diets did not fit the digest severity rating model. Okay, however, et cetera, et cetera. You'll have to read the rest of the
You'll
article to
have
get
to read
that
the
part.
article.
Yes, but descriptive statistics indicated that 67%, two-thirds of patients receiving a modified diet, modified solid or liquid, did not have dysphagia. Treatment was provided to 100% of these patients without dysphagia, right? So wasted medical costs, whole number of other things with that too. And 61% of patients with feeding tubes had no dysphagia.
Oh
45%
God.
of NPO patients had imaging during their acute stay. So That seems unbelievable to me. 45% of patients who are NPO had imaging during their acute stay, meaning 55% didn't, at least,
Yeah.
unless there's another option. I don't know.
And to the point that I think a lot of people bring up, I think it's increasingly prevalent in the discussion of what is the role of the speech therapist, is advocacy. If people are coming in with modified diets and very little information about it, we can be the people providing, generating and providing clinical data on this person's swallow
Mhm.
to go, hey, I am just not seeing any evidence here that indicates that it's appropriate for them to be on
Sure.
this diet. And in fact, here are, such as what you're, a lot of negative side effects. I've been told by building administrators, well, they had a choking incident once, or they had some sort of indicator that they're having trouble swallowing. We have to keep them on a modified diet because, that the aspiration risk or the choke risk is so big, and we can't deal with that as a building. In a litigious community,
Yeah.
while we always want to defend patients who have had negative experiences, the fact of the matter is that we can become overly protective and inhibit clinical gains
Mhm.
out of fear.
Absolutely. That is such a huge trend too. I mean, there are a few things going on with what you said. Like, one, that's a problem, right? Two, maybe there are occasionally patients for whom that is appropriate, right? But three, the hospital saying we have to do this, that removes patient autonomy from this, their ability to make their decisions, and or their family, their POAs, right? Whoever it would be in this particular circumstance, which is a big problem as well too. It takes us more
Yeah.
into like a paternalistic, old-fashioned style of healthcare. They're like, you got to do what I say. It's back to the skilled nursing facility where the SLPs are the prison guards, and they're like, we are the diet police and the prison guards. If I see thick and liquid, I'm going to lock you up and throw it away. Or, wait, thick and liquid. If I see thin liquids, I'm like, yeah, that's the kind of diet police I would want to have. But if I see you with thin liquids, I'm going to throw it away and lock
Yeah.
you up. Tell on you to the nurse. I don't know. Chew out the
Which
nurse, whatever.
I think just really leads nicely into something that you and I have discussed before, which is what are those data points we can be collecting? For one,
Imaging.
we can starting at that bedside swallow, making
Okay.
that a standardized process.
You're talking about in absence of imaging.
Yeah,
Okay.
exactly. In absence of imaging, let's start that data collection as early as possible so that we can be the people responsible for providing as much up-to-date information to the patient, their caregivers, the facility, or
Mhm.
potential next chain in the handoff process.
Sorry, I thought you were done, and then I'm like, I'm going to interrupt you. Sorry, go ahead.
You always interrupt me. It's fun. That's what makes banter good.
All right, awkward pause. I'll jump in. So I think you've brought up a good point too. Well, first of all, let's try to get the imaging. Try to develop good relationships with speech pathologists at prior facilities. Let them know like how much you value their reports and their clinical judgment and that type of thing. And if there's anything that you could do to make sure we get that for the patients who are discharged here, I would just be, indebted, because your reports and the information you write is so important, right? If you can get the actual imaging passed along, oh, that's great. That's fantastic. That's even so much better, because then you can interpret it for yourself, right? So many different ways to try and get a better handoff to get this information. But in absence of that, because I'm sure there so many people who try and try and try and are going to keep trying, but haven't gotten there yet. And so in the meantime, or in absence of that, what can we do? Not as an excuse to give up and quit trying, but what can we do now? And you're emphasizing a lot of the benefit of the clinical data we have, which, one last point with this, we really harp a lot on the importance of instrumentation, and rightly so. Like, it's very, very important. But if you're watching somebody swallow, like, you see what happens. They have delayed laryngeal valve closure and they aspirate. They have this, that, or whatever. And we might even, hopefully, can go in and determine why that's happening. Why are they aspirating? But still, there is a lot that we can bring into from like the cranial nerve oral mech exam that helps to supplement the why, so we can better understand from an underlying cause why these things might be happening that we're seeing on a video swallow study, which could result, Like say if we know or learn that there are sensory issues from a cranial nerve oral mech exam, and we see something on a modified barium swallow study that could be attributable to either sensory or motor issues. So for example, labial spillage. Why does labial spillage occur? It could be that their lips are weak, right? It could be that they have reduced muscle tone. There could be a number of things. And that's, cranial nerve 7, facial nerve. What if they have issues with the trigeminal nerve from a sensory perspective and their lips are just strong as can be, but they don't have the proprioception to feel the liquid is spilling out. But you, being the excellent SLP you are, you tested facial sensation on your cranial nerve oral mech exam. You had them close their eyes and you lightly touched their forehead on either side and had them localize where you touched. Then you did their cheeks and then you did their chin, and you find out, oh snap, they're not very good at localizing that. So maybe there's some issues with sensation in cranial nerve 5. And so instead of working on making their lips stronger, like you don't waste their time with that, because like you could bulk their lips up so much that they look like they've, I don't know what the surgery is called, but when I went to California to visit, I saw a lot of big
It's Botox.
Is it Botox? Okay, I don't know, or lip filler, or whatever.
Or lip filler, yeah.
And that's fine. It's not to rag on lip filler. I'm gonna get like hate mail now, and I'm gonna get people anyway. That is not what I meant. All right, take foot out of mouth. But we could bulk up their lips as much as we want, and it's not going to do it because they have a sensory issue. So you've brought in the importance of this clinical data that we get, and we need to really emphasize that as much, or just about as much, maybe more than some of our instrumental data for triangulation and differential diagnosis.
Yeah. And, if I can quickly talk about what I've been doing is I've been making these cheat sheets for myself because I have found the process of standardization so difficult. You go into a room, the circumstances are always different. You go in, one person greets you and just says, hey, let's get started. The next person, throws a tray at you, and you got to do a lot of rapport building before you're allowed anywhere near them, And in that process, I found that my oral mech, my intake interview were so varied. It was really hard for me to feel objective with each patient. So I made myself an oral mech / bedside chart, and it really makes sure that I hit all of the points. What am I seeing in their mouth? What am I seeing in function? Are they coughing while they're eating? Are they able to volitionally cough things up if it sounds a little gurgly in there when they're swallowing? And it gives me an opportunity to comment, and I think quite importantly, actually look at the percentages of how well they're doing. I have a 5 swallow and a 10 swallow assessment metric. This correlates with net health for within functional, mild, moderate, severe, profound. And that way it's not a guess. It's not me going, it felt functional. Well, it felt moderate. I can really look at what's going on and then compare it against the other things I observed.
But most of what we do is still a guess to some degree, but it's less.
There's still a lot of witch doctoring.
Well, no, I don't even mean that. I don't even mean that. I mean, like, there is almost always going to be a level of uncertainty with what we're doing. We're trying to make the best possible hypothesis and test that hypothesis, but we don't always have an exact reason. So that's just what I wanted to point out with that in particular. I mean, even with instrumental studies, it's a lot of it is still hypothesizing. Like, I believe based upon XYZ evidence with this rationale that this is what's going on, and you support your rationale. But so, like, for what it sounds like you're doing, it's not that it's making it not like bulletproof. Like, this is absolutely what's happening, but you're using what you have, you're standardizing it, you're giving it more statistical significance in trying to improve the sensitivity and specificity that you have, that you're able to have with the data you're using. And it's not like, oh, a cough means aspiration for sure. No, that's not, I don't think that's what you're talking about, but you're getting a much better standardized spread it's going to be stronger evidence and less biased, is at least what it sounds like to me.
Yeah. Well, and from there, because that's not the only data we're collecting, right?
Hmm.
So I also have a session tracking sheet where I look at the exercises and strategies that I've assigned to the patient, and I look at whether or not they're able to perform those. Do they need cueing to perform them? And most importantly, does it seem to be improving their swallow function? If not, we need to make adjustments. And then we can also tack in there for kind of low effort, high impact, which is a dynamic that you showed me and I love and think about a lot now, is looking at weight trends, percent of meals eaten. Are they having altered mental status? All things that you can usually get from the electronic medical record.
Hmm.
And it starts to overall paint in a larger picture, which you can then show to caregivers, in your space in the continuum of care that you can hand off to the next therapist or just to the patient so that they know what the health concerns are. Because this picture that we're painting with this data doesn't just go into a hole, or at least it shouldn't.
Hmm.
We hope it doesn't. And so now we have this process by which we are saying, this is what dysphagia means in our clinical
Hmm.
relationship with you, patient. This is what I'm concerned about. This is what I'm
Sure.
seeing.
Yeah.
And I want you to understand what I'm seeing. Here's some numbers. Let's put numbers on this.
Well, with some of the things you mentioned, you give it context. Like you talked about, you at least mentioned, did you mention UTI and confusion? Something,
I
something.
did.
Okay.
Yeah.
So I consider them like anchors. We look at nutrition, hydration, quality of life, and pulmonary health or overall health, adverse outcomes, whatever you want to call it. And so it gives context not to just like, well, hey, your swallow is dysfunctional and this is what we see, but it's like, this is why that might matter. Because the patient, not being trained in swallow physiology, might be like, okay, that's cool. Like, I'm different. Thanks for telling me that. But it's like, they don't maybe understand why that matters in a way that's reasonable. I know there have been lots of, scary stuff like if you don't do this, you're going to get pneumonia. And that's not what we're talking about here, but we're talking about that. I mean, a little bit of like, well, yeah, it could potentially result in pneumonia. These are some risk factors that relate to that, but I'm ultimately not the full authority in that, talk to your physician, talk to the pulmonologist, some other people, blah, blah, blah. But you're giving them a broader context for why things matter. And I think that's essential in helping to facilitate patients' ability to make their own decisions in a way that's very educated and informed.
Absolutely. And something I think you brought up last time we talked was these kind of 4 metrics for looking at systemic health, which is nutrition, hydration, quality of life, and pulmonary health.
Mm-hmm.
And so by being able to talk about those overarching health goals or, concerns, say, this is how what I'm seeing plays into this. I come in here and I seeing you're not eating a lot of your pureed meals. Let's talk about how you're probably not getting enough water or nutrition then. And being able to frame it, I think, in these larger categories is really important for patients understanding. When they come to us, a lot of folks are feeling sick. And while getting their food and their how they chew micromanaged for them can sometimes be a frustrating process,
Yeah.
a bewildering process. Like, why are you in here? I've been eating for 80 years. I know how to eat.
Well,
And
yeah.
so being able to tie it back to those larger health concerns, I think creates buy-in, makes people go, oh, I
Sure.
hadn't thought about that.
Well, and with a lot of our geriatric patients, they are losing the ability to live independently in so many other ways. They're losing control over their lives. And so I think we have to be careful not to just be one more person who's trying to take stuff away from them and trying to control their lives. I don't mean just geriatric individuals, but individuals who may have a disability or whatever it is. Many of the people we see for one reason or another have had their independence reduced in so many ways. And so by being able to communicate in such a way that acknowledges things that they value and allows them to be the decision makers based upon this, it restores so much of that independence. And you're not just in their control and say, sorry, you can't eat this anymore. I'm the authority and you better listen to me. It's like, come on, give some dignity, give some respect to these individuals. We just can't take it all away. We can't take all the control,
Yeah.
right?
And going back to that dynamic between clinician and patient, and I'm the authority figure, and you should be listening to me. I had a patient, he had this great descriptor because I came to talk to him about his swallow, and he goes, well, I have a swallowing problem. And I was like, I'm glad we're on the same page. I'm glad I don't have to convince you of that, but you tell me what's going on. And he's like, well, in your throat, there's two holes. There's the top one and the lower one. And sometimes acid comes up and it really hurts. And I was like, that is probably the most just common sense description of acid reflux I've ever heard. And it was a great moment to be like, you know what he does? He really does know what's going on for him. And I was really glad that we had the space for him to describe it and that he felt comfortable telling me what his perspective on his throat holes were,
Mm-hmm.
because it really shaped what we ended up targeting. Because for him, despite the fact that there were other issues with his swallow,
Mm-hmm.
that was the most uncomfortable thing. He was cutting out a ton of foods already to help mitigate his reflux.
Mm-hmm.
And we were able to just kind of immediately start talking about what he wanted to have change. And it was probably the quickest buy-in I've ever had from a patient.
Wow.
So
Well,
I love hearing how people talk about stuff in their own terms.
yeah, no, a lot of that's how you listen. Like you listen, you didn't have to do the geek speak. You didn't have to teach them what cricopharyngeus means or lower esophageal or upper esophageal sphincter.
Yeah.
It's like, okay, yeah, you've got these two holes. There you go.
Great.
Like that's,
let's keep going.
you get the point. Like you get the
Yeah.
point. We could call these holes whatever we want to, as long, but you got it. You got it. No, that's great. I think patients feel listened to, that we're a lot more likely to be seen as partners and get their buy-in. That's true.
Yeah, and in terms of building that buy-in, not to just keep shamelessly plugging my cheat sheets that I've made for myself, but I think a really helpful one I've done is my plan of care page,
Mm-hmm.
where I show people their primary diagnosis, their speech diagnosis. I relate it back to this nutrition, hydration, quality of life, pulmonary health concern. I say, these are the things I want to work on with you. Here are some strategies. Here's some exercises. The exercises are to tone up these muscles to try to make this more comfortable. The strategies are for when you're actively swallowing, and we want to see if maybe that makes things feel safer or more comfortable.
Mm-hmm.
And having this structured conversation with folks, some people don't like it. It's never going to be 100. But for a lot of my patients, I think it's kind of the first time people have talked to them about why their food is different.
Mm-hmm.
Why is it that they cough and turn red in the face when they are swallowing? And what are we going to do about it? I read an article, and Tim, I am truly envious of your ability to put names, dates, and titles to things. So I'm just going to say, I read an article at some point, and one of the things I found really concerning was that it stated how few patients felt like they knew what their therapy was about or why they were in it. At the very minimum, I can be providing that information. That's cheap. I can tell you why you're here, no problem.
That would be good. That would be nice, for sure. Well, as we kind of are wrapping things up, I'm looking through some of the stuff we had jotted down, just to want to make sure that we fill in any kind of gaps that we've left in our conversation. I think it's been really, really positive in many of the things that we've looked at. But here, so to summarize a bit, we talked about continuity of care gaps. And for you in particular, that has to do a lot with not having results of instrumental studies from the patient coming from a prior facility. And so you've talked about what type of things that you can do to try and get that information, right? But on the other end too, I mean, maybe it's common sense. Well, I was going to say, like, what can others do who are in the situation and they're in acute care passing off, or they're in skilled nursing passing off to outpatient care? Like, are there any other particular steps that we didn't talk about that you think they can do to make a difference?
Let's see. I think that one, making sure that you are trying to bridge those gaps with whoever is doing the handoff of patients to you.
Mm-hmm.
To making sure patients are educated on why you're seeing them. 3, making sure they have the resources available to, if if there is room for improvement or getting off of a modified diet, they have that information. You and I've talked before, for me, I sometimes only get to see patients 4 times, 10 if I'm lucky. And so I need to know that that bedside swallow didn't disappear. Here is what I'm generating from this bedside swallow. Here are my recommendations. I want you to go get a fees when you leave here. I want you to go to an outpatient facility. I want your caregiver to be responsible for this information and making sure they physically have that. I don't mean just have it in their minds. I work with a lot of people with dysphasia
Sure.
and cognitive impairments. I do not trust anyone's memory anymore, including my own.
Right. Yeah.
And so making sure that they have something that they can physically take home with them has been a really big push that I've been making at my facility.
Yeah. That's great.
A transitioning therapist can always request our records,
Yeah.
but a patient actually has oftentimes a harder time getting access to documentation than another therapist. So giving them that printout saying, this is what I want you to know and what I'd like you to do. Whether or not you do it, that's up to you, my friend. But I don't want you to leave here going, oh my gosh, I really wish I knew what I was supposed to do to make this persistent coughing go away, or how to get off these really gross pudding thick liquids that I've been eating for the last week.
Don't do that to people.
Don't do that to people. Yeah. Oh, every time I see a pudding thick or a fully liquidized diet, I'm like, that is rough. Let's see what we can do. Making sure patients know why they're doing this, that I think has the greatest effect on what they're going to choose to do, and taking the time to have those conversations. If you only have 2 sessions, guess what? Your strategies are not going to have turned around their swallow in 24 hours, but the education will have a lasting impact.
Yeah. And so not just trusting what you put in the chart, because that doesn't always follow patients from one facility to the next or follow them home. If it did, they might not understand that if it's a patient, not just trusting that they're going to remember what you say to them, not only, of course, the potential memory issues, but a lot of people are saying a lot of things to them. And so it's a lot to remember when they're in a vulnerable time when they might be sick. Well, probably are, right? They're in skilled nursing care. But anyway, so providing something that is language appropriate, specific for this patient that they can take with them and look at, so that you've leveraged your skills as a communicator, as a speech language pathologist, for knowing your audience, right? And as a dysphagia clinician. So that's brilliant. Another thing, so making the most of your data. So you talked about, in absence of instrumental data, different things that you can use to try and to gather, to standardize what you have, to get a lot of data points so that you can have a solid rationale on what you're doing. And you've brought up the idea of clinicians need a defensible rationale for what we're doing, right? We can't just say it's intuition. My gut tells me this. I don't want to go back to the court thing, but that's a possibility. And even if you don't get taken to court, have a good rationale for what you're doing. Sleep well at night, right? Do what's best for the patient.
Yes.
Just keep a clean conscience. That sort of thing too. But is there anything else that we missed that you think is just, we gotta touch on that point, Tim?
Honestly, I think that I would probably, kind of piggybacking off of what you said there, is if you feel frustrated at work or bored, or that what is the point of me seeing this patient? I already know how it's going to go. This is what our previous sessions have been like. That is such a good indicator that something is going wrong. Whether it's that your plan of care that you developed isn't fitting them right, or, it could be wildly inappropriate to them. Like, it requires a lot of cueing and they don't have the cognitive capacity for that.
Sure.
Or they're refusing a lot. Take that time to just readjust. I know this isn't sort of a reflection or on what we have been talking about, but that clinical gut instinct and sometimes those negative feelings of, what am I doing? I feel like I'm not making an impact, which motivated me to create a lot of these processes that I've been trying to implement in a more standardized process, guided me there, and I think that if we all reflected on those ups and downs we have as clinicians, we'd find that it's trying to tell us something. So,
Sure.
let your feelings guide you a little bit. It's okay.
Look further into that. Like if you're feeling some way persistently, it takes the time to analyze that, to reflect a bit and try to better understand why, which it sounds like, you've done a lot of that, and then it's helped you tremendously to be able to be more content with what you're doing and provide better service for your patients.
Yeah, 100%. One of the biggest errors I see in nursing communication is in the admissions. What the hospital uses for diet textures is not always what gets written down for us as the admitted texture, because sometimes nursing isn't educated on what those titles mean. And so somebody who's on a regular texture but dental soft, I think it's like IDSI 7B, not 7A, will come in and they've been put on mechanical soft or a dysphagia mechanical, which in my facility is actually like a ground texture. And so they are just being given a wildly inaccurate one. So taking the time to say, you know what, I keep having this very frustrating process of trying to look for why this diet change happened. It turns out it's actually an education problem within my own facility. Let's organize an in-service. Let's take time to talk to the director of nursing.
Yeah.
So yeah,
analyzing,
just lean into it.
Problem solver. That's great. That's great too. And you said something a moment ago about, basically it made me think of ongoing data. So if your patient's not making any progress or that sort of thing, I think it's important to emphasize that this whole idea of getting data is not just like, it's not just during your evaluation, that you're constantly getting more information because patients change, right? And you get more evidence for or against your clinical hypotheses. So that's important, doing that as an ongoing process. And also what you've emphasized, I think, multiple times is the need to be reflective and analytical for this on an ongoing basis too, which is good.
Yeah. And one more, and this is my final shameless plug,
Fine.
which is that was actually the impetus for my friend Emily and I to start a speech podcast. We call it Speech Talk, and where we found that we were just calling each other in the car being like, I cannot believe this is happening over and over again. So we started reading research, and then we started recording, talking about reading research, and, just turning that frustration into a fun opportunity to learn. And I think that has actually been somewhat of my greatest achievement, is consistently reading research and talking about it with somebody.
Good deal. Good for you. So check that out. I'm gonna strong arm for a quid pro quo and be like, you gotta say something about this on the air, or not. But if you want to, that'd be great.
You got it.
Anyway, well, thank you for being here. This has been a pleasure. It's not the first conversation that we've had, and I'm sure it will not be the last. If you have any questions, don't hesitate to reach out, and we will see you next time.
Thank you, Tim.
Don't go anywhere yet. 3 recorded courses were just released: a cranial nerve specialty course, respiratory muscle strength training course, and the Swallowing Cinema case series. Check them out at swallowthegap.com or learn.medslpgap.com. Additionally, I'm also planning a 10 to 12 week motor speech disorders class for beginner to intermediate level learners. If you're interested, shoot me an email to tim@swallowthegap.com. Thanks so much for hanging out today. If you are interested in a particular topic or even being a guest on the show, shoot me an email. We'd love to hear from you, and thank you for everything you do to make this field better.